Well, hi there and welcome to episode 24. I believe I promised a guest speaker, and I think I've got to stop promising things on this podcast because it's almost like I'm setting myself up to fail. I had hoped to have Nicola Salmon on the podcast today, but that's the problem when you have two ADHD autistic folk trying to organise a recording. You totally think you can fit it into your schedule, and then you realise that you massively underestimated how little time you had. So that's been postponed, and that is stressing me out because I've been doing a kind of like having a guest on every 4 episodes, and now we've messed with the pattern, and I don't like that. I don't like messing with the pattern, but that's okay. That's okay. This is actually a good thing for me. It is taking me out of my comfort zone. It is messing with the patterns, and that's a good thing. That's a good thing. Perfectionism is overrated. I'm not going to make any more promises because I just think that's asking for trouble. So it's all right because I've got stuff to talk about. I've always got stuff to talk about. Once again, I have my notes on a piece of paper. Oh nuts! I forgot to turn my phone off. Oh, how embarrassing. Let's have a look. Turn that off. It's fine. It's fine. Very professional. And my notes. See, again, you can hear the paper rattling, can't you? And now I can't find them. Well, that's stressing me out even more. It's right. Okay. I probably should do this first and then press record. Note to self. We'll do that next time. Anyway, we're going to be talking today. I think I'm going to call this podcast, this episode, Reimagining Health, which is the name of my free course that's out now. I say course, I don't want you to think this is some kind of massive commitment, like you can do it in less than an hour, but it's sort of, I wanted to give you a flavour of what my courses look like. I found a new course platform. To be honest with you, I just wanted to play with the new course platform, but I thought, hey, I can play with the new course platform and do something productive, and so that's what I did. So it's a free course. You can download it now from my website and pretty much everywhere else. There should be links everywhere by now, but I've called it Reimagining Health, so I thought I'd call this episode Reimagining Health because it's kind of going to work in tandem with it. Like, you can have both, you can do one, you can do the other, depends on what you're into really. I'm all about trying to create resources that appeal to people's different learning styles or listening styles or whatever, because I know some people like to read stuff, some people like to watch videos, some people like to listen to podcasts, some people like to do all three, and I want to make sure that you can. All right, stop waffling. It's out and it's called Reimagining Health, and it's basically, I think this happened when I was on holiday. I came up with a kind of, I don't know, is it a framework? I think it's a framework for how I am beginning to understand that term health in a very practical way. So how it's helping me with my clients on a daily basis, my one-to-one clients, how we look at health together, and in particular their health. So I wanted to share some of that with you. And before I start, I want to talk to you a little bit about, I basically want to tell you what I learned in medical school and as a doctor. I want to tell you what it is we're supposed to be doing. And of course, medical school took years and I was a doctor for 20 years. So I'm going to try and shrink that down into a half-hour podcast. It's not going to be everything, but I want to give you a flavour of the things that we were taught when we were in medical school. How we are supposed to practice. So let's start from the very beginning. First you do all the anatomy and the pathology and the physiology and all that jazz, and then eventually they'll let you out on the wards to talk to patients, and you're taught how to do a patient intake basically. And we start off with a history, and the first thing is the history of the presenting complaint, because you're complaining. I mean, that I think now looking back, it sets a tone, and I never thought about it, but it sets a tone for all of medicine really, is that patients are complaining. That's what they're doing. They're complaining about their symptoms. And it's our job to sort of manage that. And when you hear the word complaining, you think of an angry person and customer services. You think of a child complaining to their parents. You think of like a YouTuber like complaining to their audience. I don't know. The word complaint is just it's a terrible word. It's a terrible way to start, because that's not what people are doing. They're coming to us, their trusted quote unquote health professionals, to help them with something that is really upsetting, because we are dealing with life and death, quite literally, life and death. When someone comes to see us, no matter how, in our opinion, minor their symptoms are, they're major to the patient, to the person, to the individual, because it's disrupting their life enough for them to go and seek a doctor, right? So like it's important. So I to begin with, there is the issue of complaining. And so we wanted to find out, what are you complaining about? We call that the history of the presenting complaint. So like, when did it happen? How did it happen? What is it? That kind of thing. Describe the symptoms to me and all that jazz. That's pretty simple stuff, right? I think anyone could do that. I've got chest pain. Cool. Tell me about it. Usually when people say that, I'm not so relaxed. I'm like, you've got what now? Anyway, so then we need to know the past medical history. Notice how we've drilled down into medical history straight away. So it's history of presenting complaint, and then it's past medical history. And included in that could be past surgical history as well, if it's relevant. So we need to know about the physical stuff. Tell us about your physical health from when you were a child until now. Anything else? Anything else? Anything else? We're very interested in your physical health. And then we are also interested in any medications that you're on, any allergies that you might have, any investigations that you've had. That's very important, investigation history. Sometimes we do what we call a review of systems. Now, that's a very medical school thing to do. I don't know that I've done that very often as like a GP. Not that we have time. Don't forget, as a GP, I only have 10 minutes to do this. So a review of systems is literally to go through all of the systems. So we're still very invested in physical health here. So let's talk about, you can start at the top. You can go top to bottom. So you can start off with neurology, and then you can do like eyes, ears, nose, throat, heart, respiratory, gastrointestinal, and so on and so forth. That you can do it that way. But you basically like, well, have you got any sickness and diarrhea? Have you had any, loss of weight, change in appetite, blah, 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 blah. You have to ask all these questions. That's called the review of systems. So we've focused very heavily on physical health, and then we're like, we probably ought to do a social history, because social history is very important too. It's not like it's like a thing that we do at the end, and we're particularly interested in social history. Like, you'd be told off if you didn't ask about things like smoking and alcohol and drug use and perhaps sexual health if it's relevant. Obviously, like if you're doing a psychiatry rotation, it's going to be slightly different, right? Like, you're going to be interested in mental health, not physical health. So bear that in mind, that it is going to be slightly different. If you're doing obstetrics, you're going to be interested in obstetric health and so on and so forth. But like just general medicine now, we're talking general stuff here. So social history, maybe we might want to know who lives at home with you, or just basic stuff. What do you do? Do you have a job? Are you retired? Are you on benefits? Stuff like that. So we do think about that, but mainly we focus on physical health. So once we've got all the facts in hand, the next thing is the examination. And again, like when you're in medical school, you get taught to do a full examination. There are very specific rules about how you examine a patient, and like, what side of the bed you must be on. You're only allowed to be on one side of the couch if you're a doctor. And my physical therapist friends and all of my allied professionals find this hilarious, because oftentimes it's really difficult to like reach the opposite side. They don't care. They'll like go around the couch, like sensible people, but not if you're a doctor. So then you do an examination, which, by the way, I want to point out, like, not every doctor examines their patient. And I think I've told you this many, many times. If you're a fat person, you are far less likely to have an examination. Doctors don't like to examine fat patients. They also don't like to examine disabled patients or older patients. Any patient that's going to require a little bit more effort, right? Like, this person's going to take a little bit longer to get undressed. I don't really want to examine them then, because that'll take more time. Or, this patient's a bit fat, don't like that. If you're watching me on YouTube, you can see my face. I'm like, which oftentimes doctors don't hide that. They don't try to hide that. Like it's there on their face and they don't care if you see it. So that's the examination. You're lucky if you get one nowadays. And then the next thing you do would be investigations. And like you will have from the beginning, right from the history of the presenting complaint, you will have started to formulate in your mind a kind of what we call a differential diagnosis, which is lots of different things it could be. It could be this, it could be this, it could be this, it could be this, it could be this. And there are like things that's unlikely to be, but we definitely need to rule out. So things like malignancy, cancer, it's usually not cancer, but we also need to make sure that it's not cancer. So it's very near the top, like how do we rule this out? So we're either trying to rule things out or we're trying to rule things in. And so by the time we've done the examination, which should confirm or help us rule in, rule out things, we then go into investigations. And investigations are where we tend to rule things in and rule things out. We have become so, as a profession, heavily dependent on investigations, which makes me really sad. I remember when I was doing dermatology, it was one of the best clinicians I ever worked with, actually, one of the best doctors I've ever worked under. She had a rule, especially with her junior doctors, that you did not look at the rash until you had a diagnosis. You had to have not just a differential diagnosis, but you had to have a working diagnosis before you were allowed to look at the rash. And she used to do this thing where she would like come in. So like you would do the intake. So it wasn't as a medical student. I was a junior doctor, but still you do the intake. Then you go, which is very unusual. Normally, you go to your senior with the plan. You're like, okay, I've diagnosed this and this is what we're going to do. But she wouldn't let you do that. You had to go to her and then you could go and see the rash together. And it was really good fun. Like she did this as sort of part of our training and it was a load of fun. So I only did like 4 weeks with her. But I loved it because she said very clearly, you can make a diagnosis without ever seeing a patient. You should be able to make a diagnosis from the history alone. And of course, you're not going to get it right 100% of the time, but it's good to have that. And we just stop doing that now. Like we've become so heavily dependent on investigations that we don't try and engage our brains. We like write down the information and then we're like, well, I have to do this test and this test and this test to decide. The problem with that is that tests aren't that reliable. They're not that accurate. Lots of people will have quote unquote normal tests and still have a condition. And so if they're not 100% accurate, then like we shouldn't be dependent on them, but we are. And we have got so dependent on them that they override our own, brain, our own like investigative, and also there's also something to be said about, it's not necessarily gut instinct and intuition, but our intuition is honed over years, right? Based on our experience, based on all the patients that we've seen. And there comes a point in time when we're just like, I have a gut feeling I know what this is. Or, yeah, I've seen this so many times before. And even if the tests come back negative, like I still think I know what this is. This has happened before. But we stopped doing that, which is such a shame. Anyway, that's not the point of this podcast. Where was I? So investigations. Okay. And then we come to the diagnosis part. And we can't always make a diagnosis straight away, but we can have a working diagnosis. And this is when, it's been shit from the beginning if you're a fat person, because right back from the fact that you're complaining, like if you're complaining, and if you think about this, when a person you like complains to you, it's easier for you to listen and to be present than if it's someone that you don't like. If it's someone that you don't like that's complaining to you, you often just switch off right from the beginning, right? So this, when I said this is setting the tone, it goes wrong from the beginning. Already the moment you walked in the door, as far as a doctor is concerned, you're here to complain. And if he doesn't like you or she doesn't like you or they don't like you because of who you are, because you're fat or because you're disabled, because you're black, because you're trans, whatever, they don't like you. Deep down inside, they don't even know that they don't like you. It's implicit bias, but they don't like you. So the moment you start talking, as far as they're concerned, it's like, wow, 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 from someone they don't like. And that's terrible because that's not what medicine's all about. But because of that, it's been crap from the beginning. So taking the history was crap, the examination part was crap, the investigations part was crap. But the diagnosis part is when it goes terribly wrong. Because thanks to anti-fat bias and weight stigma, doctors tend to blame your symptoms on your weight. And they started blaming your symptoms on your weight right from the beginning when they were taking a history, which means they weren't paying attention. They weren't thinking about all the other things it could be. They weren't focusing on the things they needed to focus on. And so when it comes to making a diagnosis is you're fat, which is horrendous. I think this will be a podcast episode, actually, but my best friend asked me the other day, how can someone die of complications of quote-unquote the O word? And I went, they can't. And she's like, yeah, but the singer. And I was like, yes, I know about the singer. We all know who I'm talking about. And I think I need to do a podcast episode on this, but it's a sensitive subject, so I haven't quite approached it yet. But no, you can't die from complications of the O word. But the point is, we've got to the stage in medicine where we are actually blaming fat for like symptoms. People have been fat for centuries. We didn't blame them for anybody ever of their symptoms. You know, you wouldn't go to a doctor and say, I'm this, and they'd be like, oh, it's because you're fat. No, even when I finished my training, we didn't have the audacity to do that. It's only more recently that we can just confidently say, oh, that's all because you're fat, and if you lose weight, you'll feel better, which of course is not true, and we know this, and I've talked about it many, many times. But the diagnosis, how are we supposed to make the diagnosis when we don't have all the facts? And when we're so busy blaming weight that we haven't even attempted to gather all the facts, how can you possibly make a diagnosis? I mean, just pulling it out of thin air. After the diagnosis, we move on to treatment. And of course, you can't treat something unless you know what it is, and you don't know what it is if you haven't got all the facts. So it all goes back to the very beginning. But when it comes to treatment, I've written down here on my notes, doctors are gatekeepers. This is really problematic. Again, we get to decide if you can have a particular treatment or not. And sometimes our hands are tied, because, there are some things I'd love to prescribe patients, but I can't because I'm not allowed to, or, because of the local policy or national policy, or because it hasn't been approved by the National Institute of Clinical Excellence or whatever. There are times, but oftentimes it's because I decide, right? Most of the time I decide. And, sometimes it's really simple. You've come to see me. You've got an ear infection. Your eardrum is bulging. It looks like it's about to burst. I'm like, yeah, you need antibiotics, because if you don't have antibiotics, it's going to be very unpleasant for you. And even then, I don't force people to take antibiotics. They might have a really good reason for not wanting to take them. But I say, look, I can see what's happening here. The solution is antibiotics. Here are the side effects. What do you think? And 95%, 99% of the time, they're like, yes, please, can I have the antibiotics? That's simple. That's simple medicine. That's easy medicine. I don't even need 10 minutes to do that. And sometimes it's a case of okay, well, we have an idea of what's causing it, but it's not that straightforward. So here are all the options. And then I give them the options, and then we decide what we're going to do. But, at the end of the day, I could just not, I could say, no, go away and lose some weight, and then you can have this treatment. And that's often what happens. What a position of power. What a position of power. And then knowing just how deeply prejudiced we are, how much bias we hold, implicit bias we hold, to give us that power, it's not just unreasonable, it's dangerous. And we know it's dangerous because we've seen what happens when doctors are given that power and how we abuse it. And it's not necessarily got to be something dramatic. Sometimes it can be something that would, that others might consider very minor, but it's not minor. It impacts your whole life. So this is what I was taught to do from when I was literally in my early 20s. And what I've been doing ever since is how you do it. And I don't think much has changed. I suspect medical school training is exactly the same now as it was in the early I started medical school in 1998, so the end of the 20th century. I bet nothing much has changed. We are not exactly a profession that evolves with the times, hey? I mean, we are in some respects, but not in others. Anyway, I find that this is a very flawed system, and it's whilst it is the way it's always been done, I think it's wrong. I don't like this way of doing things. And I think, when I've thought about it, like for me, the problem is that we are so fixated on physical health that we forget everything else. And you could say, yeah, but you're a doctor, like you do physical health, Doctors like, we're not social workers, and we're not. I agree with that. We're not social workers. But to think that means, therefore, that social well-being is not important. I'm not a psychologist, sure, but to pretend then that emotional and mental well-being is not important means that you're only ever going to get a very small part of the picture, because your physical health is intrinsically linked to all the other parts of your health. So I was thinking about, like, what are the parts of your health? And, I did an entire podcast series, I think it was season 2, wasn't it? I asked 12 different guests for their definition of health, and all 12 different guests gave me 12 different answers. And that's to be expected. And so what I learned from that quite early on, actually, this kind of prompted a lot of the thinking and reflecting and researching that has taken place in order for me to come up with this framework I'm about to tell you about. It got me thinking that actually, even like when you try and find a good definition of health, and there are some terrible ones out there, the WHO definition is terrible, but there are some better ones out there. But even the better ones, I'm always like, yeah, they're good, but they're lacking something, especially when it comes to the kind of practical implications, because sometimes I find a definition, I'm like, oh, that's really good. Like, how do you apply that to like everyday medicine? Every day, like in and out, seeing 20 patients a day. Like, how do I 20? Oh God, that's wishful thinking. 20 patients in the morning. Like, how do I like practically apply that to that situation? And the answer is, in 10 minutes, you can't. But I've come up with my own framework, and it's my own thing. Like, it may well intersect with other people's frameworks, but that would be accidental. It's not like I've gone around reading other people's and borrowed some and modelled them all together to form my own. No, this has all come out of my own head. So it might be shit, might be good, you don't know. I use it a lot with my clients, and that's what I've covered in Reimagining Health in the little mini course. And that is, I talk about relationships. That's how I try to understand health in terms of relationships. Bear with me. I talk about relationships with the relationship with yourself, the relationship with other people, and your relationship with the world around you. I'll say that again. Your relationship with yourself, your relationship with other people, and your relationship with the world around you. And I believe all 3 of these relationships are of equal importance and will interact with one another. So when it comes to your relationship with yourself, you are a physical being, and therefore that's your relationship with your physical body. It's also a relationship with your relationship with your thoughts and how they impact you. Your feelings, which are separate from your thoughts, but again, work very much together with them. And I also put joy and pleasure in here as well, because it's something that gets missed out, which is a travesty, because I believe that accessing joy and pleasure is one of the most healing things a person can do. So physical health is just one part of your relationship with yourself. And of equal importance is your relationship with your thoughts, your mental health, your relationship with your emotions, which, again, we would categorize that under the umbrella of mental health, but not necessarily, because thoughts and emotions are different. And pleasure, joy, you put sexual health in there, and food. Food would go in there, for me anyway, because I find it pleasurable and joyful, and some people don't, but for most people it does. So that's one thing. And then there's your relationship with other people, again, of equal importance. So I've got family in there. And of course, your relationship with your parents, the 2 most important adults in your life for the first 7 years, which is the most important part of your development. So your relationship with your parents, your relationship with your siblings. And of course, family history is something that we pay attention to, but only when it comes to what diseases do your family have. Like, we're not interested in anything else, which is terrible, because your relationship with your parents kind of defines you. Well, certainly, defines a lot of you. And one of the things I learned in medical school, and not in medical school, but certainly as a junior doctor, was that I couldn't get much done if I didn't understand the family dynamics. Like, it's all well and good taking a history and having a diagnosis, but I'm not going to be able to do much more unless I know who lives at home and how much support do you have, etc., etc. So even on a practical level, understanding family dynamics is important. But understanding it in terms of health, hugely important, as is other relationships. So obviously, if you're in an intimate relationship, or it could be friendships, etc., like, how are these impacting you? Community, also really important, and something I talk a lot about with my clients. If you have a supportive community, a found family around you who are there to build you up, to lift you up, in whom you can form healthy, balanced relationships with. We all know this is massively important. In fact, there was, and I think I wrote a blog about it and possibly even did a podcast about it, a study that came out that looked at the various risk factors for all sorts of diseases. And one thing they found was that social isolation was one of the biggest risk factors. And they were talking about social isolation and how important it was to deal with that. And I was like, I've been saying this for a while. Community, relationship with other people is really important for your health. I put money in there as well. Does it fit? I think so, kind of. I don't know. Maybe I'll have to put it somewhere else. But money comes into it as well. Because let's face it, if you have money, more likely to be healthy. And then there's your relationship with the world around you. And that can be your physical environment. Like, it could be things like clean air and clean water, and it can be access to green spaces. It could be about safety, and like that comes up over and over again when we're talking. Like, are you safe? Do you feel safe? So safety is a huge part. So it could be it could be your physical environment, but it can also be much more kind of like your kind of the environment as a whole. So like, politics would come into this, the political environment. There will be groups of people who know that, depending on whether if you're in the States, live in a red state or a blue state, or, wherever you are, like depending on what the laws are like, it's going to massively impact you. I mean, practically speaking, if you want an abortion in certain states in the US now, the political landscape is going to massively impact you. And that's a very sort of obviously, glaringly obvious kind of point, but actually it can be much more subtle than that. So yeah, the political landscape, and that can really impact. I have a client who is massively impacted by what's going on in Palestine and just hasn't been able to kind of breathe for the last 8 months because of the crap that's going on. So yeah, that's important when it comes to your relationship with the world around you. And this is where I put something very important, which is stigma and discrimination. If you are experiencing stigma and discrimination in your life on a regular basis, it's very difficult for you to be quote unquote healthy or well. Does that mean you can't be healthy if you're experiencing stigma and discrimination? I don't know. I think that's for you to decide. But this is a huge, important part of your life that we doctors just don't even think about. It doesn't even cross our mind. We are focused on your relationship with your body, really only your relationship with your physical body. We might, depending on what field we're in, be interested in your sort of mental well-being and your emotions. We might. Joy and pleasure we could give a fuck about. We're just like, we don't think you deserve it. No, I'm just kidding. That's not true. Maybe we're interested in family dynamics. Maybe. But that's about it. I'm willing to bet there isn't a doctor out there that sits down and goes, right, so tell me about your experience of stigma and discrimination. I do. In fact, I have when I fill out my summary for my clients, when I see a client first time, we do an initial assessment. I do a summary. And I do it mainly because I think it's something like 70 to 80% of what's discussed in any consultation is forgotten. So I'm like, well, you don't just want 20%, you want all 100%. So I write up a summary so that all the salient points are in there, and the things that I've picked out that I think are relevant go into the summary. And there is an entire section in there for dieting history, and there is an entire section in there for medical stigma and trauma. For weight stigma and medical trauma, I should say. Yeah, because that's so important. But I bet you there aren't that many doctors out there that are going, oh, clean air? I mean, it might be relevant, but most of the time we're not even thinking about it. So how can we can try and fix the physical thing, and maybe sometimes, like with the ear infection, fixing the physical thing is enough. Doesn't mean you're going to be healthy, by the way, because you might have an ear infection and lots of other things that are making you unhealthy, but at least it fixes the ear. Oftentimes, symptoms are not that simple. And, things like fatigue is a classic one. Pain, especially chronic pain, gastrointestinal symptoms, migraines. I'm trying to think what else. Like, there are certain sort of symptoms or groups of symptoms that will often have numerous factors interplaying with one another. An ear infection is caused by bacteria getting into your middle ear. Pus is forming, your eardrum starts bulging. It's really quite unpleasant. And then if you're unlucky, it perforates your eardrum, then all the gunk comes out. Yeah, gross. It's horrible and it's very painful. But we know what causes that. Bacteria got into your middle ear, and sometimes there's a reason for that. Most of the time it's not, it's just bad luck. That's an ear infection. But fatigue? Sure, it could be caused by hormones. It could be caused by, you're low in certain nutrition. So it could be nutritional, but there's so many other things that could be causing it. So I actually think that our understanding of health, and I'm talking now, if you're a healthcare professional listening to this, or if anyone, it doesn't matter, whoever's listening to this, our understanding of health is very, very kind of tunnel visioned. We are interested in the physical, and we forget about all the rest. But all the rest impacts the physical. Like, I can't stress this enough. Happiness, joy, pleasure. One of the most healing things that I can suggest. More joy, more pleasure, more happiness. I know it works. And I have studies to show that, but also I've seen it work. But I mean, like, it's not even something that we think about. At no point in time when someone's talking about how to improve your health do they go, more joy, more pleasure. Hedonism. Anyway, did I get to the end of my notes? I think I did. I said talk about my framework. That's all I said, which I kind of have. And it's been 33 minutes. That's good. That's a nice time. Check out the course if you can. I have something really quite special planned in the next few weeks. I'm very excited to talk about it, but I'm just going to bite my tongue because I tend to get ahead of myself. And as I said, not making any more promises. But in the meantime, if you think to yourself, do you know what? My doctors have just not cared about any of these things. And I'm listening to this and I'm like, oh, that would explain so much. That's why have had the symptom for a really long time and no one's figured out what's wrong with me. It's because they actually haven't bothered to look outside of this very narrow parameter. Then you can consult with me, right? Like, you can just book a consultation. And if you're not sure if you want to, then you can book like a discovery call before you book the consultation. It's all through my website, headtofatdoctor.co.uk/consultations. And find out exactly what I offer and whether it's something you'd be interested in. And as I said, you can go ahead and book. I love working with people, and a lot of people have said to me, I'd find it very hard to sort of toot my own horn, but I'm going to do it. A lot of people have said to me, wow, that's literally the best medical consultation I've ever had in my life. Thanks very much. Considering I don't have the ability, it's not possible for me to examine you because it's virtual. It's not possible for me to order investigations because I'm not your registered practitioner. And it's not possible for me to treat you. And as I said, like, it was history, exam, investigations, and then treatment. So considering I could only do the history part, that's quite a compliment, isn't it? That people still found that it was the best medical consultation they've ever had. So, it helps that my initial assessments take 90 minutes as opposed to the 10 minutes I have in general practice. That definitely helps. So anyway, come find me if that's something you're interested in. Come back next week. I am going to sort of be kind of continuing on from this. We did sort of medical student how to be a doctor, so how to be a doctor 101, and we're going to go kind of like into the more advanced how to be a doctor stuff next week. Don't forget to join me. See you then.